I think I just would make a few comments about the toxicity of treatment with Rucaparib. So it's very important in the maintenance setting that you have a drug that's well tolerated, because many of these patients will be taking the drug for a long time. And we were very pleased to see in the Ariel 3 trial that the toxicity was broadly manageable. Nausea, fatigue, anemia, those tend to be the key toxicities with most of the PARP inhibitors. There is a slight difference between the three, which may emerge with time, but by and large the toxicity was mild, so the number of patients with grade 3 or greater toxicity was really relatively small across all those domains that we looked at. And the number of patients discontinuing treatment because of toxicity, which I think is a very important parameter of acceptability for long-term therapy, was also low with Rucaparib. It was 13.4%, which again falls in line with most of the other PARP inhibitors. It's not uncommon to need to make dose reductions, and I think this is a very important learning point for all of us as we use these drugs outside of clinical trials and clinical management, that we understand that these drugs are dosed, flat dose. They're not adjusted by height, weight, surface area. So a number of patients are going to need not only dose reductions, but perhaps even short periods of interruption. And I think the most important message to get across is not to stop these drugs too early on the basis of side effects. So in the trial, as I've said, we've managed to keep all but 13.4% of the patients going by interruptions in therapy or dose reductions. About 50% needed a dose reduction, and overall about 70% needed either interruption or dose reduction. But with that, you can get most of these patients through the treatment.